Hi, my name is Nancy Pham, and today we will be discussing pulsatile tinnitus. Our learning goals are to define pulsatile tinnitus, review its pathophysiology, and then discuss a series of pathologic lesions as well as normal anatomic variants. Pulsatile tinnitus is characterized by rhythmic sounds, which are synchronized with the heartbeat or pulse and correlates with systolic and diastolic flow during the cardiac cycle. In contrast, non-pulsatile tinnitus refers to constant noise. Pulsatile tinnitus can be subjective or objective. In contrast, non-pulsatile tinnitus is often subjective. However, the most common form is subjective. Pulsatile tinnitus can arise from both vascular and non-vascular causes. Vascular causes can be further categorized into arterial causes, venous causes, or high-flow vascular malformations. Non-vascular causes include masses and tumors of the external, middle, and inner ear, as well as osseous disease of the temporal bone. In terms of imaging workup, my personal preference is to obtain a CT temporal bone to look at the osseous structures and to obtain an MRI of the IAC, which includes dedicated brain, IAC, ASL imaging, in addition to vascular imaging at our institution. A catheter angiogram can be performed as needed for confirmation of the pathology and for treatment. However, there is institutional variability on this protocol. The potential mechanisms leading to pulsatile tinnitus includes altered blood flow that can lead to turbulence, vibration of a dehiscent vascular wall, or a third window effect. Lastly, as a reminder, hyperdynamic cardiovascular states such as hyperthyroidism, hypertension, or anemia can also lead to pulsatile tinnitus. It is also important to recall that the continuity equation for fluid dynamics states that there is constant flow through all regions of a pipe. Thus, a decrease in the diameter of a pipe, for example, in a region of stenosis, will lead to increase in velocity and thus turbulent flow. And this turbulent flow is perceived as pulsatile tinnitus. And this mechanism is relevant to some of our arterial and venous causes. So with that in mind, let's look at the venous category. The first case is idiopathic intracranial hypertension. The imaging findings include dilated and tortuous optic nerve sheaths, flattening of the globe, optic nerve head protrusion into the back of the globes. There's usually associated with a partially empty sella. On venous imaging, there is bilateral stenosis of the transverse sigmoid junction with turbulent flow leading to pulsatile tinnitus. This patient received a right dural venous sinus stent with resolution of the pulsatile tinnitus. A sigmoid sinus diverticulum and sigmoid plate dehiscence can also lead to turbulent flow, as well as abnormal bone conduction. So this patient had a left sigmoid diverticulum with thinning of the adjacent sigmoid plate, best seen on the coronal image. This was repaired with 3 layers, a soft tissue graft on the inner layer, a bone cement in the middle layer, and a bone graft on the outer layer. A jugular bulb, diverticulum, can also result in abnormal sound conduction due to its proximity to the auditory canal. This patient had a superiorly directed diverticulum along the left jugular bulb. On DSA, this was confirmed and then treated with coil embolization with resolution of the symptoms. A high right jugular bulb can lead to abnormal sound conduction to the middle ear. As we scroll through the axial images, the jugular bulb rises at least to the level of the basal turn, or IAC. Next, we will discuss the arterial category. Arterial abnormalities include carotid stenosis, carotid dissection, aneurysms, fibromuscular dysplasia, and arterial variants. However, the common mechanism for aneurysm, stenosis, dissection, and FMD is turbulent flow through the arteries. So this patient had over 90% stenosis of the right ICA from both calcified and non-calcified plaque. The patient underwent a right carotid stent with resolution of the symptoms. This patient presented with a left carotid dissection and pseudoaneurysm at the skull base. This patient had a left paraclinoid aneurysm that was subsequently coiled. This patient had multifocal beating of the carotid artery on the right on both CTA and MRA, consistent with FMD. So arterial variants that can lead to pulsatile tinnitus include a persistent stapedial artery. This is an anatomic variant arising from the ICA and passes through the stapes foramen. Of note, during development, it contributes to the formation of the EAC and then involute, but in some cases, it can be persistent. And when it is, it passes through the stapes foramen. Often the left foramen spinosum is either hypoplastic or aplastic, as demonstrated by this yellow arrow. And on coronal image, we see this tubular structure along the cochlear promontory. As we scroll through the axial images, we see a tubular structure coursing from the posterior aspect of the petrous ICA, and then it ascends through the stapes foramen to the level of the facial canal. Another important anatomic variant is the variant IAC. This results in a more lateralized ICA in the middle ear, as well as a more posteriorly positioned ICA in the middle ear on axial and coronal images. High flow vascular malformations result in pulsatile tinnitus due to its high blood flow to the lesion as well as shunting. This particular patient had multiple causes for pulsatile tinnitus, including a left schwannoma. However, on time-of-flight imaging, there was prominence of the left middle meningeal artery, as well as abnormal flow-related enhancement in the left transverse sigmoid sinus. ASL imaging confirmed a vascular shunt compatible with a dural AVF. This patient had an AVM in the left masticator space and mandible. DSA confirmed multiple arterial feeders and draining veins, and this lesion was embolized. This patient had a right traumatic carotid cavernous fistula. On imaging, there was right proptosis, abnormal flow-related enhancement of the cavernous sinus, dilatation of the ophthalmic vein, and then serpiginous vessels compatible with venous congestion of the right cerebral hemisphere. ASL imaging demonstrated shunting in the right cavernous sinus and ophthalmic vein. As mentioned earlier, non-vascular causes included masses and tumors of the auditory pathway, as well as bony abnormalities of the temporal bone. So a cholesteatoma is a collection of desquamated squamous epithelium with erosion of the adjacent osseous structures. This patient had a prior right mastodectomy and stapes prosthesis for a cholesteatoma. On the current imaging, we see a soft tissue mass in the EAC and middle ear. On MRI, there was no enhancement with multiple foci restricted effusion compatible with recurrent cholesteatoma. One example of a periganglioma is a glomus tympanicum, which arises from the glomus bodies located on the cochlear promontory. There's a lobulated mass along the left cochlear promontory on coronal and axial images. This was dotatate avid on PET-CT, compatible with a periganglioma. A schwannoma is an example of an IC mass that can lead to pulsatile tinnitus. On MRI, it is T2 bright, enhancing, is identified along the right IAC and CPA cistern, and it's likened to a sideway ice cream cone. Next, we will go over several bony lesions that can lead to pulsatile tinnitus. Superior semicircular canal dehiscence can lead to a third window effect by shunting outside of the oval and round window. The third window results in abnormal sound vibration as well as pressure dissipation, leading to altered sound perception. On imaging, there's a defect in the superior semicircular canal on Stenver's view, as well as Paschal's view. Lastly, in otospongiosis, there is focal demineralization, as well as vascularization of the bone, which may contribute to pulsatile tinnitus. A stapes prosthesis is often placed to improve hearing function. This patient had a right stapes prosthesis with vestibular protrusion and a lucent region at the left fistula antifenestrum, compatible with otosclerosis, otospongiosis. On axial image, there is bilateral lucent regions compatible with fenestral otosclerosis and otospongiosis. In summary, we discussed the pathophysiology of pulsatile tinnitus, as well as both the vascular and non-vascular causes on imaging. Please feel free to reach out with any questions, and thank you for your attention.